geography. And really those pieces of wealth, race, or geography, those are some social determinants, and we'll dive into those a bit more throughout the presentation. So just to do an overview of the social determinants of health. So what they are the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health and quality of life outcomes and risks. And they can be grouped into 5 major domains, including economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Now, I'm a fan of hearing things from different mediums, so I'm going to start off with this brief video, and they are going to go over quickly just what the social determinants of health is, and also this comes from HHS. So I'll just play this in 1 second.
At HHS, we define the social determinants of health as the conditions in the environments where people are born, live, learn, work, play, worship, and age. Social determinants affect our health, well-being, and contribute to health disparities and inequities as well. Healthy People, our nation's longest-running disease prevention and health promotion initiative, emphasizes addressing the social determinants of health to create environments that promote health and well-being for all. I'm Admiral Rachel Levine, Assistant Secretary for Health at the United States Department of Health and Human Services. Healthy People 2030 provides a framework for thinking about the social determinants of health across 5 domains. Here are the 5 social determinants of health. First, economic stability. People with steady employment are less likely to live in poverty and more likely to be healthy. By helping people earn steady incomes, we can achieve economic stability for all. Second, education access and quality. People with higher levels of education are more likely to be healthier and live longer. By helping students excel in school, we can improve educational access and quality. Third, healthcare access and quality. Many people in the United States are unable to get the healthcare services that they need. Increasing access to high-quality healthcare services will ensure more individuals can attain their full potential for health and well-being. Fourth, neighborhood and built environment. Health and safety risks like high rates of violence and unsafe air or water impact health and quality of life. By creating safe communities, we can provide opportunities to promote playing and physical activity. And fifth, social and community context. Increasing relationships and interactions with family, friends, neighbors, and community members is beneficial to an individual's health and well-being. To learn more and see how others are working to address the social determinants of health across the nation, please visit healthypeople.gov.
Great. Well, I think that video provides a great overview of those 5 major domains. And I really like this chart from the Kaiser Family Foundation, which breaks down those domains and gives you a little bit of insight into the different factors that actually make up each domain. And they pull out food as a separate one, which is really the only difference. So I'm just going to go through a few of these to give you an idea of how those really play into health. And I think you'll start to see that some of these really correlate with one another, can affect one another. So for example, employment. So we know that with good paying jobs usually come good benefits, things such as paid time off, sick leave, things that we might, if we have regular 9 to 5, good paying jobs, we might take for granted or not really realize is actually a privilege and a luxury when you look at families that work hourly jobs and might not have those that time to take off. And so if it's a pregnant woman and she's working an hourly job, she might have to make the decision of, do I call out of work and take that unpaid day and go to my provider appointment? Or do I miss that provider appointment because I really need to be able to keep my bills paid and, everything for my family while taking care of? Income. So we know that some higher paying jobs come afford us a few more things that we're able to pay for that really affect our health, some ancillary services and goods. So things such as healthy foods. We know fruits and vegetables are a little bit more expensive than maybe some processed or some frozen foods. And so if we look at a family that really doesn't have a lot of expendable income, they might not be able to pay for those better quality foods, and they might have to buy foods from the dollar menu um, just to make sure that their family is fed. They might also not be able to pay for co-payments or other payments that might come to support the health of their family. Looking at the neighborhood and physical environment, the housing, the quality of housing is so important, because when we look at some of these houses with poor housing qualities and have mold and mites, we know that those can exacerbate respiratory illnesses in moms and families, especially pregnant women and their baby that's developing. It's a serious, serious concern. Transportation. So you'll see a little bit later in the presentation, but about 7% of households in Broward County don't have a vehicle in their home. And so this really limits their ability to maybe come out of the suburbs or go to other areas where they could get a better paying job with those better paying benefits. They might have to travel to go to a provider's office. They might have to travel for some of the other services that they need. So if they don't have that vehicle and they're really relying on that public transportation or other modes of transportation, that can severely impact their ability to go to those provider appointments or their ability to get some of those better paying jobs. Is the neighborhood safe? So in the video, I think they alluded to the safety of a neighborhood. So if a community isn't safe, then families aren't going to opt to, go outside and connect with one another. They're going to stay in their home to avoid that. So that's limiting their ability to have some of that physical activity and social interaction. Does the neighborhood have parks and playgrounds? We know that that's going to be a way that children and families can get some of that physical activity in. But if they're not those in the community, or they're really not up to standard, some of the families might not want to go access those parks and playgrounds. Walkability. So some of these poor communities actually don't even have sidewalks where they can enjoy walking through the neighborhood, and it's dangerous to walk on the streets. Zip code or geography. We'll see this a little bit later, but really where a community is and the resources that make up the community really impact the health outcomes. I think you all can probably just come to, some communities might come to mind that are under-resourced, and you'll probably think about the fact that they don't have a lot of those assets like parks or playgrounds, or it's not very safe to go through them. So it's really just an important point to think about, that those communities already have, if they don't have the parks, if they don't have the sidewalks, that's already limiting and posing a barrier to some of the health behaviors we really try to promote to ensure those optimal health outcomes. Looking at education. So in public health, we like to say to put materials out at a third grade reading level, because you never know what the literacy level is of families. So when you think about health information, we want to make sure that it's really going to resonate with them. And if it's something that we want to help them make a behavior change, they really need to understand what they're being taught. And kind of just going back to that point of some of these poor families, they might not have the ability to stay through all the schooling that they need to. They might have to leave schooling early, which affects their literacy rates. And those are the populations in the groups that we want to reach the most, because they have some of the poorest health outcomes. Language. So in Broward, there's a significant population that speaks another language. And so we want to make sure that when we're putting out information, that it is accessible to all types of people. And for example, when they're going to their provider appointments, that they are empowered to find a provider that speaks their language, that understands their culture, to make sure that they really have that rapport together and put them in the best position to take that advice and implement those healthy behaviors. Early childhood education. So we want to make sure that these schools that children are going to, even before they're going to kindergarten or primary school, that they're quality education, that they're not just seen as a daycare, because school readiness is so important. And if children are already behind when they get to kindergarten, it already puts them behind when they're going through their future schooling. Vocational training and higher education. So as the video stated, higher education leads to better paying jobs, more expendable income to pay for some of those other assets that'll make us have healthier lifestyles. And so is the quality of schooling that students have in the communities setting them up to be able to access that higher education, or is it under resourced and really that, higher education isn't even an option for them? And if higher education isn't their route, are there vocational training programs in their community so that they're able to learn a skill that they can then monetize as they get older and into adulthood to really break that generational poverty cycle? Looking at food. So hunger and then access to healthy options are two different things. A family first is going to focus on, can I feed my family? I'm not even thinking about what are the types of foods I'm feeding them. I just want to make sure they're fed. So this really hit home. I was driving to the west coast of Florida this past weekend and through some of these rural communities, and there's no Publix, there's no Winn-Dixies. What you see are Dollar Generals, which are full of those frozen processed foods that are low cost, but they don't even have the access to some of those healthy options. And even if they did, it might not be affordable for some of those families. As the video stated, community and social context is so important. Having that social support is critical for our mental health and our well-being. And some of the communities, especially those of color that face a lot of discrimination and racism, start to internalize that stress, which can then lead to poor health outcomes. And then finally, the healthcare system. So again, going back to those good paying jobs that typically come with good health insurance, where we might not have to pay as much out of pocket, we might not have to pay our premiums as much, but we know that hourly jobs typically don't have that structure in place. And so while a family may be on Medicaid, they might also make too much to be on Medicaid and have to purchase a plan on the marketplace, which is so costly. I mean, those are hundreds of dollars that really needs to come from a place of having that expendable income and seeing healthcare coverage as a priority. Provider availability. So are there providers that are close in the community? Because if we think back to that point of transportation, if a family doesn't have a mode of transportation, then how are they going to get to those provider appointments? Are they then having to rely on public transportation, which might take 2 or 3 different buses to get to that provider? And then also the point of linguistic and cultural competency. We want to empower folks to look for providers that are similar to them so that they can really feel confident in expressing their needs and get good tips and good behaviors that they can implement in their own home. In years ago, when safe sleep was an issue and we were hearing that we were hearing a lot of infant sleep related deaths, we were learning that a lot of families culturally would co-sleep with the babies. So it really took getting into the community and learning from the different cultures to try to stop that messaging and reframe it in a way so they would understand, because just hearing from the providers, no, don't co-sleep with your baby, wasn't enough. We really need to take a look and understand the culture where an individual and a family come from to be able to give them targeted solutions that's going to work for them. And then finally, the quality of care. Are the individuals and the family's needs being heard and understood, or are they just being dismissed? Because if that's the case, then a lot of things can be missed. Joan and I were just speaking the other day, and we were talking about Serena Williams and her case of she was expressing her concerns to her provider over and over, and they weren't paying attention. And it's because there's this stereotype or this stigma that exists that Black women can have a higher pain tolerance. And so their needs are not addressed as much. And that's something that really, from a provider standpoint, we are trying to push implicit bias training so they can understand everyone has their own biases, but we have to do the work to really challenge that and make sure we're looking at each person as an individual and not just coming in with our preconceived notions. So each of these factors and each of these domains really lead to these health outcomes. So they could be differences in mortality rates, morbidity, as well as life expectancy, which I believe is the next slide. And I think the life expectancy really puts a lot of these factors into a very clear way. So I'm going to X out really quickly from the presentation just to show you that there is this tool from the Robert Wood Johnson Foundation called Life Expectancy. Could where you live influence how long you live? So what you can do here is actually put in your address or zip code, and it'll tell you what your life expectancy is for that area. So I'm going to put in the, because I recently moved from Broward to Palm Beach. So my zip code here in Broward.
We're still seeing the presentation rather than the tab that you're working on.
Thank you. Let me try to reshare that. I always forget to switch the screen. Okay, can you see it now? Okay, great.
Yes, thank you.
Thank you for pointing that out. So as I mentioned, it's a tool by the Robert Wood Johnson Foundation, Life Expectancy by Zip Code. So you just put in either your zip code or your address, and then you can see what the life expectancy is. So the life expectancy in Broward County, since I didn't put a full address, it's just the county, it's 81.2 years. You look at Florida, Florida is about 78.9, and the US is 77.3. Now, if I do it to my current zip code, I gain a whole year, 82.29. And that's just one county over. Now, the point that I would say is critical too, within county, there are stark disparities. And I'm sure you all could come, some different areas are calling to your mind, and you could even look those to see what those might look like. But this is really a culmination of, as we were talking about, all those social determinants, is there playgrounds? Are there sidewalks? Are there access to healthy foods? All of these play a role in how long we're going to live, just as one measure, because there are so many other measures that we could look at. So let me go back to the presentation. Well, actually, I'll just pause here before I go into this video, because I think it's about 4 or 5 minutes. So I want to just pause and see if there's any questions or any comments thus far.
This is Charlotte Barry. I'm new to join the group, and this has been really well done. Thank you so much, and for bringing up the issues addressing the social determinants of health in our own communities. Thank you.
Absolutely. All right. Well, I'm going to go ahead and play this video. Oh, sorry. Go ahead, Linda. Oh, sorry. You're on mute, Linda.
I know, Jim. I don't know if you're going to talk about this further in your presentation, but you illuminated the problems beautifully. Is there discussion about possible or probable solutions?
No, I was thinking about that earlier. I feel like we can have some open discussion at the end about what that might look like. I think because we're all, passionate about health equity, as we talked about. So I think we can definitely talk about that at the end.
Okay, thank you.
Yeah.
Or you can come back for part 2.
Oh, okay. Part 2. All right. I'm going to go ahead and do this one. Oops. Oh, no. All right. Maybe I'll play it from in here.
To best grasp the political determinants of health, let's examine a hypothetical example.
Sorry about that. I'm not sure why it just paused. I don't think it wants me to exit the screen, so I'll just leave it in here.
To best grasp the political determinants of health, let's examine a hypothetical example that combines experiences of real people in urban and rural communities. Imagine a 19-year-old woman, we'll call her Jessica. After enduring several miscarriages, she barely survives giving birth to an infant 9 weeks early, the baby weighing only 3 pounds. Her son is placed in the neonatal intensive care unit, the blood from his umbilical cord revealing over 200 toxins. Where did the system fail Jessica and her baby? How and why did these results occur? 3 years earlier, Jessica had left her parents' house. Access to treatment for her dad's substance use disorder had been eliminated when policymakers closed 3 of the city's public community health centers to save money. Contending with his wife's lack of education, neither of Jessica's parents could secure a job with a livable wage, prompting serious and substantial mental health conditions. Jessica moved to a low-income neighborhood in the city. She never knew of the extent of how the appalling conditions of her neighborhood were politically determined. For example, determined to keep housing segregation in place, politicians expended very few resources to build sidewalks, parks or recreational facilities. Healthcare providers refused to operate in Jessica's community due to poor reimbursement rates from Medicaid. Because they resisted creating bus routes, lawmakers dissuaded grocery stores from operating in the community, preventing residents access to fresh fruit, vegetables, and meat. Simultaneously, policymakers altered zoning laws to permit development of a dump site and a chemical plant, switching the community's water source from a clean river 10 miles away to a nearby polluted river to save money. This water was used to drink, bathe, and wash clothes. It also irrigated the lawn at Jessica's apartment building, adding to the list of pollutants and environmental hazards in her neighborhood. And because her district lacked established tenant rights, her landlord had no interest in improving unhealthy housing practices. Jessica found work as a cashier at the corner convenience store, a job with no employee benefits, including health or disability insurance. Because policymakers rejected proposals to increase minimum wage to a livable income, Jessica often substituted her employer's free snacks policy as a meal, never realizing the effect that high-fat, high-sodium food would eventually have on her or her baby's health. With local politicians striking down an effort to ban smoking in convenience stores, Jessica was constantly subjected to a barrage of secondhand smoke. And when she discovered she was pregnant, no attempt at receiving health insurance coverage was successful. Her non-ACA compliant plan denied her maternity coverage because they viewed her pregnancy as a pre-existing condition. Medicaid, the government's health insurance program for low-income families, denied her coverage for not being poor enough. After finding a ride to the free clinic, Jessica waited more than half a day to be seen by a second-rate physician, a doctor who was condescending and offensive. Realizing she could not afford to take more days off from work, she never went back. At 31 weeks, a neighbor drove Jessica to a hospital ER 20 miles away. Seeing that Jessica was experiencing excessive swelling in her face and ankles, as well as seizures, the emergency team decided to deliver her premature son immediately. Due to complications, her newborn son was sent to the neonatal intensive care unit. Once his organs were deemed mature enough, he was taken off the machines and sent home with severe cognitive defects. And in their apartment, Jessica and the baby were exposed to mildew and cockroaches, causing her son to develop respiratory problems. The landlord refused to remedy the poor conditions, telling her to move if she didn't like it there. Jessica struggled to find early childhood care and access to schools with educational assistance, healthy food options, and other resources needed to thrive. Because their school and community lacked the resources to enable Jessica's son to even barely reach his potential, he dropped out of school after entering 8th grade, just as his grandmother had done, repeating what is surely the ongoing rule of poverty. Jessica's story shows the compounding effect of political determinants over personal responsibility. No matter how reliably Jessica tried to act, structural, institutional, intrapersonal, and interpersonal obstacles stood in her way. Political determinants were pulling strings that prevented Jessica and her family from achieving optimal health and their full potential. What does this mean for all of us? What can we do to improve and mend our community's most damaged systems?
All right, so now I just wanted to bring everyone back and see if anyone had any thoughts or reactions that they wanted to share. Paula, I see your hand.
You know, it's these kinds of, it's not just these stories, but these real examples of people's lives that I think move, particularly those of us in this arena, to action. And as gut-wrenching as we're all feeling with this, we can't be stymied by the feeling, you know, Linda was saying, are there things we can do? And there are absolutely things we can do, and we can feel very, I mean, I'm holding back tears because that's my reaction, is an emotional reaction to this, but I also must find the strength to move past that very visceral reaction to feel like there are things we can do, because sometimes we can feel that the problem is so big that one tiny little bite isn't going to help, and we can't allow ourselves to do that.
Absolutely.
And Caroline, Paula is another one of our league members who has taken action and developed the blood pressure cuff project in her county. Thank you, Paula.
Thank you, Caroline. I work with Desiree Schnorr. I think we were on an email together as well. So we've worked with our local March of Dimes and are hoping to do some, they have partnered with our Moms with Monitors program, which, would this be a good time to feel good about something, or shall we wait until
I
the
think
end?
so. I
Yes.
think we do that.
If this is a good time to feel good, our league followed Nancy's lead out of Palm Beach County. Thank you, Nancy, and T. Leroy Jefferson Medical Society. We want to make sure and always give homage to their efforts. We had done a big deep dive into social determinants of health. You're doing a great job covering them. And as well as looking at all of the access to care and transportation and all of these other things that make up these roadblocks and restrictions to good health care. And knowing the things we know about that Black women are 3 times more likely to die of complications during childbirth and for pregnancy, knowing that our preterm birth rates in Florida, in Polk County, I don't have your numbers right off the top of my head, but maternal and infant mortality, preterm birth rates are pretty abysmal in Florida and in most of our counties. We really wanted to take action and embraced the strategy of Moms with Monitors that Nancy and T. Leroy Jefferson had come up with. Ours was very different than the way they did it. Theirs was as a pilot program and had very specific parameters with it. I would suspect that if any of you all consider doing it, either from Broward or if there are other leagues here, it will likely take on a look that looks a little bit more like what we've come up with Polk County, because we've done it through our Department of Health and have created some corporate sponsorships and programming through our own minority health liaison, and have had just amazing support. Our Department of Health has recently purchased roughly $5,000 worth of blood pressure cuffs to give to our most vulnerable pregnant women in Polk County who are Medicaid. We're very, very excited. We think we may be getting an additional bit of funding from March of Dimes, and I've written some other grants for it. So once that occurs, then we'll really be able to see, we're using our county data to be able to follow our maternal and infant mortality data as well as our preterm births, because we cannot forget preterm births. You got to see in Jessica's story about how not having access to care to create a preterm birth and all of the disabilities that are created by that, all of the challenges for families, continues to impact in such a significant way.
Yeah.
And so if we can at least keep our mamas and babies safe and going through to at least to term, that is another good thing. So what happens is our moms are given a blood pressure cuff. They take their blood pressure during the week. They report back to their provider, whether it's an OBGYN or their doula or whoever is providing the care. In our case, it's a OBGYN. And then that physician or PA or whoever will then dictate what the care is. So they will say whether they need bed rest, which I know all of these things have problems, but bed rest or medication or whatever their individualized plan is, that blood pressure cuff is a pathway to success during pregnancy. And we know that research shows it. So we are very excited to be able to help our mamas and babies and families really thrive during this time. So I just want you guys to know there are things to be done. And whether you choose Moms with Monitors or you choose something else, I serve on the Health Equity Task Force. Your minority health liaison is required to have a health equity task force in your county. I wiggled the way in so that our league had a spot on that very early on. So we are actually looking at all of our social determinants of health and coming up with a project as a county for what we're going to concentrate on. So I'm trying to just be the hope factor here and not Pollyanna and brushing off the significant problems that we have, but to say that you can do this. So that's it.
Thank you, Paula. You're stepping before us is very inspiring, you and Nancy, so thank you.
Yeah, Paul, and I think you made a very good point of kind of using the data and seeing where the needs are. And Joan and I have talked about that. And if blood pressure cuffs is really the most pressing need, or is it gestational diabetes, or really what are those factors that are leading the maternal deaths, maternal morbidity, infant, all the things that come with maternal and infant health. And each community is so different in their needs. And since I have such a large service area from Miami to Vero Beach, I'm learning more and more about each community and where the gaps lie. So just for example, in Palm Beach County, the transportation service to care through Children's Services Council is phenomenal. They will provide rides to pregnant people, to the grocery store, to their visits, to their child's visits, all of these wraparound services. But I'm learning that in Broward County, transportation is an issue, and setting up that kind of taxi service or whatever that might look like. So my former colleague who was working in Broward was working on that transportation issue. So I think it's, like you're saying, taking the time to look at the data, to talk with, whether it be pregnant people or whatever the populations are, to learn in their, from their perspective, what are the needs that are there. And then I told Joan the other day, I love this non-traditional collaboration, because so often it's been, the health department or everyone working in silos to work on these issues, but it's only through all of us working together. I think if someone heard, oh, the March of Dimes and League of Women Voters are doing a presentation together, they might say, oh, well, that's an interesting, but it really is something like we talked about that everyone needs to know about the social determinants. And you all have, the passion, and I think also kind of that gateway of getting folks interested in voting and interested in advocacy, so they can start to feel empowered and realize that they have a voice too, and they're the constituents. They're often the ones that come from those disadvantaged, under-resourced communities are really the ones that have the most power. They just don't know it yet.
So Caroline, along that same vein, we have included in our presentation to our Department of Health that they will give out a voter registration form along with their cuff. And so we have said that's very important to us. We are nonpartisan, but we feel very, very strongly about that. The other beautiful thing about this effort that we're doing in Polk, following, of course, Palm Beach County, is that we're laying the foundation to be able to say, oh, well, they did it in Polk with their Department of Health. So now there may not be quite as many obstacles, because if there is a known program that's been accepted, we know there's a lot of bureaucracy. So we've kind of cut through some of that, so that our minority health liaison has said they will be more than happy to talk to others in other counties to be able to say, we can make this work. So I think that's also part of the battle as well, as we're talking about these things.
Yes, I saw Linda's hand first, and then we'll go to Nancy after.
Thank you. First of all, to Paula and to Nancy Gow, kudos to you, honest to God. You really do lift up our spirits. But I wanted to ask Caroline, I know Joan Sternberg has made multiple attempts to reach the liaison in Broward County, and seems to constantly hit a wall. Have you had any luck reaching that person or communicating in any way with that person?
I haven't yet, but I did put a note out to the woman that was in the position before me to see if she did, so she can make that connection. So I definitely will keep you on the loop.
Okay,
We're going to keep trying.
Oh, I know you are. It's just, I know how hard you've been trying, Joan, and how long you've been trying, and it's frustrating.
I guess there was some frustration in the department because they were trying to fill the position with somebody.
Well,
So,
but we've got a name now, so,
yes.
all right. Thank you, ladies.
Nancy?
One, excuse me, one comment. Wasn't actually why I raised my hand, but in answer to Linda's concern, we have had a lot of difficulty here in Palm Beach County communicating with our liaison as well. And I just found out yesterday, communicating with Ruth Brandwine, our counterpart over in Sarasota County, her liaison has already changed. So I'm suspecting that is not really that going to be that unusual, because we
Yeah.
know the way these government agencies work, and most of these liaisons were not newly hired. They
Right.
were already Department of Health employees in their
Right.
in their locales, and they were just given this as another assignment. And in
Right.
some cases, like I just found out in my case, we actually have two. So Ruth had to start all over and communicate with the new person. Luckily, she
Mhm.
was very responsive. So keep that in mind. Don't
Yes.
give up. There might be,
No.
if that person could already be somebody else. Another thing you might do, the co-chair of my healthcare committee here, Dr. Brent Schillinger, knows a lot of people in this community. He was former director of medical
Let's see.
society here. He contacted Dr. Alonso, the head of our health department, Dr. Alina Alonso. I'm sure you've all heard of her, especially during COVID. So you might think about contacting whoever your Dr. Alonso is in Broward. Maybe they might be able to nudge that person as well. That person probably reports to her or him.
You're
Also,
right,
that might-
Nancy.
that might
Because
be-
excuse me, go ahead.
Nancy,
Go
those are
ahead,
great
Paul.
suggestions. Those are great suggestions. Joan, also, if you email me or text me separately, I'll give you the contact to our person and they could probably get you in touch with yours. Additionally, there was our regional health liaison was on this last health equity call. So there are also regional liaisons as well. But if you could just reach out to me, if you don't mind, and remind me that you need that, then I'll give you her email address and I'll connect you guys together.
Yeah, I was going to say ours, I think, is already working with an HIV program. So she's doing that and now she has this. So there may be a learning curve or she may be short-staffed, but we'll get there. Thank you. Yeah.
The other thing, Joan, which I originally raised my hand for, something else to Linda's question, what else can we do? Don't forget telemedicine. Do everything you can to support promotion of telemedicine. This is something that has a huge impact, as we saw through COVID, on these type of situations with people who have no transportation. So we're putting the tool in their home, the blood pressure monitor. And with telemedicine, they don't need to go to the physician as often. They've got the tool in the home and they've got telemedicine to communicate to the physician. Yeah, not only through legislation. There was legislation this past session about telemedicine.
Yeah.
Medicaid is starting to pay for it more and more in some states. So keep that in mind too, as something you can support even with grants possibly.
And also,
Yeah, thank
the
you.
legislature also passed one additional year of postpartum care that many people
Right.
don't know about. Most people don't know about. So even just getting that message out of the 12 months postpartum care for Medicaid, I'm sorry, I might have said Medicare, for Medicaid. So that's a significant change. We're also looking at doing community baby showers with our migrant populations,
Yeah.
just to throw out some other.
Yes.
Yeah, on that note, before I go to you, Maria, Desiree, my counterpart on the west coast of Florida, she is working with the Florida Health Justice Project. And I think the hangup was with the postpartum Medicaid extension. It was, Florida had submitted the waiver and then the feds had to approve it and then give us the funds. So I think it's kind of, as far as, I think it's still happening. It's just we're waiting on that funding to do like a campaign and bring it to the different counties to really start to educate the pregnant people that it is 12 months now. So I'll definitely make sure to keep in contact with everyone here too, so we can just blast it out as much as we can. Maria, I see your hand up.
That expansion, that 1-year expansion was, if memory serves me, was written into the budget rather than legislated. So does it last past the year of that budget? Because it was last year's budget, wasn't it? Maybe I'm wrong.
I don't know those nuances, but that's a good question.
And no,
It-
my question had to do with the video. I know it gave a compilation of a lot of the different scenarios that compounded that person's situation. There was one part, and I wanted to make sure if I understood. Did they deny her because they said pregnancy was a pre-existing I didn't understand that when I heard that. Why would they consider that a pre-existing? But that was the basis of denying her the healthcare benefits that she.
Yeah, you're correct, and that's what the video stated. I'm honestly not an expert in the Medicaid area, especially when it comes to pregnancy Medicaid. So I'm not sure if that varies by state as far as whether they consider that a pre-existing condition or what. Does anyone here know?
I don't think that that would necessarily be the case. From most of my research with things, I would be very surprised if a pregnant woman. Now I know that what in the video they were saying, they're basically just compiling every possible everything is my perception of it. But if she's actually in Medicaid, but what they also said was that she missed the Medicaid cutoff because she made too much money. So I'm not sure that this was a reference to Medicaid not covering it, because I can't imagine Medicaid not covering
Okay.
pregnancy. And I'm not sure that private insurance can do that anymore either, but I'm not an expert on that, so can't really speak to it.
Yeah, and this video I think is a few years old, so I'm not sure also if it was kind of framed differently. Yeah, that's what I thought too. Maybe too much for Medicaid, not enough for ACA. And then it's always wonky, especially here in Florida, that kind of in between.
Yeah, but I have the same question. Pregnancy is or it isn't. It's a very black and white issue. How, Nancy, you're a doctor. How has it become a pre-existing condition?
No, I'm not a doctor. I think you're thinking of Dr. Nancy
Yeah,
Stotts
I'm sorry.
up in Jacksonville. That's okay. I did work in healthcare though, but I think Caroline just hit the nail on the head. I think that's outdated.
Yeah, I think so too, or
That would be my
misspoken.
guess.
Misspoken, yeah.
Right.
Maggie, I see your hand up.
I was thinking that maybe it was just because she was pregnant before she applied. And so the application said it was a pre-existing condition to her application. And
Oh my
so,
God.
I mean, that's what I got from it. And I've heard that before. So that's what I think they're doing to eliminate having to help her, because she was pregnant and then applied.
And one of our guests said that in the chat as well.
Yeah, but I'm not sure Medicaid can still pull that kind of crap. Private
Why?
insurance might, but I don't think Medicaid could, but I'll look it up.
Oh, I thought it was the private insurance. I didn't think it was Medicaid. I don't know that Medicaid would pull that.
I don't see how anybody can make that statement.
No, I don't either, except that they're insurance companies, what can you say?
I mean, the
Yeah.
Affordable Care Act just totally annihilated that argument. If
Right.
you've got cancer, you can't be denied insurance.
Well,
And that is federal law.
Right, so,
Despite our
Uh,
governor, it is federal law.
yeah, I'll have to look into that. I don't know, that's the first I heard that.
Yeah, I think that had to be a mistake. It just has to, I can't wrap my mind around it not being a mistake.
Right, or outdated.
Yeah.
And does anyone know what the standard policy is for maternity leave? It depends if they're part-time or full-time, really, or?
What do you mean leave? That would come from the
If-
employer, or you're saying as far as coverage?
For FMLA,
Or as far as, I'm in education, so I know if when a teacher takes maternity leave, their job is still guaranteed to them when they come back, whether they're paid during the leave or not. does that apply in all fields, or that's one of those luxuries?
Yeah, I believe that depends on the employer.
Yeah,
The federal law is applied differently to different sized employers. For instance, if you're Publix, you've got a very different thing than if you're the mom and pop cafe trying to make it down the street. So it really depends on, I believe it's based on the size and the participation, the number of employees that they have, for instance. Great questions, everybody.
Yeah, I know you all are so great with the information, the questions in the comments. I had a few more slides. I'm just gonna breeze through them really quick because I know we're coming up on time. And it seems like this group is pretty well versed, but I feel like health disparities and health equity is often terms that we hear and we might not understand exactly what they are. So health disparities is when there's a health outcome that's seen to a greater or lesser extent between populations. And often we talk about racial or ethnic disparities, but they can also be based on sex, sexual identity, age, etc. And health equity is when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged because of any of these social factors. So the chart here, or the image here, shows, we think of equality, one size fits all, everyone gets the same, but equity is really tuning into what does that individual need to achieve their health outcome, not just different size bikes, but also even the structural mechanics of the bike is different because every person is different, every population is different, and we should do what we can to give them, each individual, the tools to be as healthy as they can be. I was going to present some data on just economics in Broward. About 10% of the population is food insecure. About 10% of families live in poverty. Our unemployment rate is about 6%. And this last one is, so HUD uses the threshold of if you pay over 30% or more, 30% or more of your income on housing, it puts you at a risk of not being able to pay for some other items such as, what do I have here? Food, clothing, transportation, and medical care. So we know that rent is rising, but 62% of renters are paying more than 30% of their income on rent.
Broward.
And then here, just some data. About 25% of the population lives within 500 feet of a busy roadway. That's concerning because of the pollution. In Broward in 2020, about 10% of moms or births were to moms who didn't have insurance throughout their pregnancy. So that's concerning because then you don't know how often they were going to their provider and the quality of care that they were receiving. We have about 16% of our population that speaks a language other than, or speaks English less than very well, usually because they speak other languages. So we want to make sure that information is in those other languages so that all of our populations represented can understand. About 16% of the adult population had less than a high school education. About 43% lived within half a mile of a healthy food source, but conversely, over 50% didn't. And about 7% of households did not have access to a vehicle, which is concerning when we think of getting to provider appointments, getting to those good paying jobs that you typically have to travel to. And then here's just some maternal and infant health data. So this is the preterm birth rate by county. Broward is here about 11%, which is a bit higher than what we really want the goal to be, about 9.4%. And you can see here that distribution across the state. And then that it's important to also disaggregate the data whenever possible to see which groups are most affected. So you can see here that there is a disparity with Black babies, about 14% of them were preterm, compared to white babies, about 9%, Asian Pacific Islander, about 9.5%. In 2020, there were 150 fetal deaths, which is the death of a fetus before 20 weeks, or called a stillbirth. And significant disparities here as well, with Black fetuses in the county 2.6 times more likely to experience a fetal death than white fetuses. And then similar trend in infant mortality. In 2020, 101 infants passed before their first birthday, and Black infants were 2.7 times more likely to pass before their first birthday compared to white babies. And really this, although we can see the leading causes of infant mortality, of fetal death, the point that I'm trying to make here is really these social determinants that keep on piling on, that we really need to see what we can do as advocates to try to address these and really close that health disparity gap and truly get to a culture of health equity. And about 1 in 5 babies were born to mothers who did not have adequate prenatal care. And you can see that this really jumps for the Black population. Over a quarter of them didn't have the adequate prenatal care that was recommended. And in 2020, 3 Black women died of pregnancy-related causes compared to white women. And if you go years back, this is typically the trend, about 2 to 3 times more likely to pass. Like I said, there's not one reason that we can really say. We know that there's some hypertension, some other comorbidities that are putting Black women at risk, but part of it we're also finding too is Black women and women of color aren't being heard when they're expressing concerns to their providers. So it's also kind of a two-pronged approach to empower the women to take control of their health and do what they can, but also working with providers so they can kind of dismantle their the way that they are treating patients and make sure that they're being equitable in their treatment. And the last thing I want to leave you all with is March of Dimes actually has an advocacy arm. So we have both federal advocacy and state advocacy. And so if you text Dimes to 52886, you can get on the listserv for our Advocacy Action Network, and you'll get information on different bills we're supporting. And the 2 that we're really pushing for right now is the Pregnant Workers Fairness Act, because amazingly enough, employers aren't required to provide reasonable accommodations for pregnant women. So we are trying to pass a federal bill that will make that so. And then the second one is newborn screening to make sure that that is still well funded, because 12,000 babies a year, we catch things early with the newborn screening. So we really are trying to push and get as many people to support that as possible. So sorry, I just breezed through that really quick, but I wanted to make sure if anyone is interested in the data, because I know Paula alluded to it, and I'm so happy that Desiree has an advocate like you, and excited that I'm starting to form those connections with my counterparts of the leagues over here, and just seeing you all's passion. And like we're talking about, although we kind of come at the issue in different ways, we all have the same common goal, and I think we'll get there, stronger together anyway. I will X out my screen now, and we're right at 8 o'clock, but I wanted to pass it over to Joan. Sorry for the
Joan?
Yes.
It's Nancy. Before we leave, I'm on a website that's called Legal Match, and it states pregnancy is no longer considered a pre-existing condition because of the Affordable Care Act.
Well, thank goodness for that, right?
Right.
No, thank you for that information. And thank you too, Caroline, for taking your time to inform us about the very important topic. I appreciate it, and I will enjoy working with you.
Thank you so much for the time.
And thank you all for your support. It was very meaningful. Thank you.
Great job, ladies.
Thank you.
Great job, everybody. Hang in there and just do something, whatever it is, just do something, and it moves the needle. It moves the needle, really does.
Thank you, Paula.
Yes. Thank you, Carolina.
Thank you, everyone. Bye-bye.
Good night. Thank you.
Bye-bye.
Good night.
Good night. Thank you.